Okay, and can you see the screen?
And we can see the screen.
We have had a hell of a time in 3 minutes. We have been trying to fine-tune the machine, and I think more or less it works. It's a 33-week fetus, so it's a little bit big, but it's okay. I am looking at the head, and if you want, we can start with some Dopplers. Is that right?
Absolutely. So what I thought we could do, Edward, is to start with the more traditional measures for assessment of growth restriction and then move to the more specialized measures, especially in the assessment of third trimester growth, SGA babies, where actually the Dopplers will often be pretty normal.
So we start with, I'm sorry, because I could not hear you very clearly. We start with a typical measurement of the brain arteries. Is that okay?
Absolutely, yes.
Okay, now I heard you much better. So now I am more or less, it's babies in breech. So you have to fight a little bit more than usual to find the right section. But more or less when you are in the DVP measurement, more or less, you go a little bit down, and then I will zoom now, and then you see all this, and the focus, I will put the focus a little bit higher. And you see the vessels there without Doppler, they are all, and now we will switch the color on, and we have to reduce a little bit the PRF to have a better image. It's not the perfect image that you would be expecting here, indeed. But anyway, you can see the circle of Willis. You know it's there, and all this color, it's reflecting the polygon. Can I have an arrow? Yes, and so that's the middle cerebral artery, that's the posterior, that is the anterior branch. And so we have to measure the Doppler here, close to the circle of Willis, but not very close, because then you will take the carotid, the highest part of the carotid. So I will switch on the pulse Doppler. The size of the gate is 3 millimeter. You could reduce it to 2.5 probably to be more or less the size of the vessel. And then we will have the Doppler of the umbilical. We got 3 signals that were of good quality, and just for the sake of time, I will not. You should normally repeat it 2 or 3 times, but you should try to get 3 of these waveforms of high quality. And I think, well, in general, we prefer to have 3 waveforms in a row with of the same size. But well, we have a couple here. We could. So they are not exactly the same. They should be exactly the same, but for the sake of time, as I mentioned, and then the PI. We will. So we'll take a couple of them, and then we will measure the PI, and that's it. So that's how we get it to D. Okay, and we can move, if you want, to other vessels. We could go to the. Do you want me to do an umbilical artery, or we just go directly to the ductus venosus?
I think you can go straight to the ductus venosus,
yes.
Except one of the things I wanted to highlight, which came out in Edward's talk yesterday, was not just measuring the umbilical Doppler, but also the MCA in the third trimester is of importance. And
yes.
There are now normal ranges for the cerebroplacental ratio, or in other words, the division between umbilical artery and middle cerebral artery.
Okay, so we'll go for the ductus. The ductus, the classical ductus measurement is this baby is more or less lying, that's time in the middle line, so it looks it's a little bit with back in the front, not very much. So the classical measurement of the ductus is you go to the spine, you move a little bit to the left of the patient, and then you see the umbilical vein, where there are a lot of shadows here, but is there an arrow? I need the arrow. Okay, so there should be somewhere around here. So you switch the Doppler on, and we have a lot of color here. So we have to increase the PRF to get rid a little bit of that, and then see if we can find. Baby is moving a little bit now. So I wanted to show it in a nice way, but I cannot. Sorry, let's go again. We'll switch the Doppler off, look at the spine again, and then switch the color, and it's there. But the problem is that you see we are having a lot of noise here. We might try to change the setting because this is really the ductus is here. I know it's here, of course, but I wanted to show it well. Let's go for a higher PRF. And so this is the arrow. So this is the ductus, and you know that it is the ductus because of this hyper-intense signal. You try to change a little bit the orientation by moving. It's a very, as I say, it's a very large baby. So, and that's the signal of the umbilical vein. And at the end of the umbilical vein, we have the signal of the ductus venosus, which is here. So you know it's the ductus because of this high velocity, and you can increase the zoom a little bit, and then we'll update. Maybe it's moving a little bit, and that's why it's getting a little bit difficult. I will show you the alternative way of measuring the ductus now. So that could be one way, and but the signal is not very nice. And this happens very, very often, even in the second trimester, that you don't get the perfect position because the angle obviously is not nice. So let's go again and try with another option. And the other option for, I will decrease the zoom a little bit now, for measuring, are you okay? Yeah? The other way is to try to take this transversal or axial approach where you try to get the ductus in this other orientation. You go to the heart and a little bit down the heart, and then you switch the color. And here these are the suprahepatic veins that you should not mix up because they have this trident-like. So you go a little bit down, a little bit more down, and the ductus is here. We make the zoom. The angle is not perfect, but it's much better normally. So now this is the moment, especially when you're in a demonstration, that the baby starts moving. But you put here, then you can close a little bit the gate just to make it 1.5, maybe 1 millimeter. The ductus should be 1 millimeter now, and that's the signal of the ductus, and that's it. We will update. The angle is not perfect, and that's why we don't get such a...
But I think you're demonstrating very well, Eduard, that you can get the ductus both in the sagittal and in the axial plane, and if you're struggling in the sagittal plane, often going to the axial is preferable.
Yeah. So you get contamination with the baby is moving, so we'll get out of here and not to be too boring. And so these are the two ways of getting the ductus, this longitudinal, the classical way, and probably we have a better position now. So this is the typical image that we are looking for. This one. And I have stopped the images, and that's the... So this is the umbilical vein, and at the end of the umbilical vein, the ductus venosus goes to join the right atrium, and we can find it there. And just a little bit, I wanted to show, but it's not so easy. A little bit above the ductus, then there are the suprahepatic veins. I wanted to show them, but they are not coming up so clearly here. And it's just to show how easy it is to mix up this signal. But the signal is something you can never... the spectrum of the Doppler is so clearly always the ductus, because these are the suprahepatic arteries, and if you pick up one of these arteries, for instance, this one, we will increase a little bit. Yeah, can you update for me? Can you update? This is the typical signal of a suprahepatic artery. You should never mix up with the ductus because the velocity is much lower. It's clearly lower, and also they have this appearance of a very abnormal ductus. So, and they are really 2 millimeters above the ductus, and that is the only thing you have to take care. But if you look, you always need to see this very hyper-intense signal, and definitely this is a match.
So highlighting some of the potential pitfalls is important, the other one being the having an arterial signal on the other side, giving the impression of a reversal of flow, which can easily happen if the gate is too wide.
Okay, it's not the perfect signal as usual, but during these sessions, so you need to spend some time. The ductus is not an easy vessel, and if you want to be completely sure, of course, in this case, you are completely sure that the ductus has atrial flow, and so even if you cannot measure the perfect PI here, you can be pretty sure that it is a normal ductus. Normally you are concerned about an increased pulsatility. Okay,
Now, Edward, assuming that in late onset SGA babies or growth restricted babies, Dopplers are usually normal, we wondered if there was some additional features that we might look for that might give us clues as to whether a baby's growth is impaired in the third trimester other than the traditional biometry measures.
Well, in reality, for clinical practice, the ones that we have measured were essentially the cerebral-placental ratio and the uterine artery are the two main useful Dopplers. Ductus is going to be normal virtually in all of these cases. So if you're going to do some research, then there are some other measurements. But if you want, we can measure, we can go to the heart a little bit and look at some of these measurements. One of the measurements that we can get is the aortic isthmus, which is going to be abnormal in about 8 to 9% of these fetuses, and it's also useful in early onset IUGR, of course. So do you want me to show the aortic isthmus?
I think it would be nice to show the aortic isthmus and perhaps also some of the, I don't know how easy it might be to get a tie index, but perhaps also looking at the dilation or globularity index of the heart.
Yeah. Okay, so the classical way of measuring the aortic isthmus is baby knows what I'm going to measure, and it changes position always at the right. So the classical way of measuring the isthmus is looking at this section of the aortic arch. You see, you see the supraortic vessels coming up here, and this is the last one. So the aortic isthmus is here, okay? You can switch the color on if you want to make it, we should increase a little bit the scale, the PRF. And so this is the aortic arch with the supra-aortic vessels, and the aortic isthmus is this part that it gets a little bit narrower, and that's why it's called isthmus, and just before the joining of the ductus arteriosus. So that should be here. So you can measure it here. Now we'll try now. I should increase a little bit the gate, and then I will zoom a little bit to have a nicer image. Okay, thank you. And it should be around here. You see, the angle is not perfect, even if I'm trying my best, but then I cannot get a perfect angle. I went trying to center the image, and well, actually the angle is horrible. so I will show you the other way of measuring, and I really cannot get a nice. I'm trying to force a little bit, but the baby is really fleeing from me. So that's where you can get it, but you have to wait until you get a real image of an aortic isthmus, because that is nothing. That is a disaster. Okay, but that's the way of measuring, and then let's look at the other approach. And the other approach, just go to 2D again. And the other approach is this. Let's take the zoom out and reduce a little bit the size. And so the aortic isthmus was described in this projection I mentioned, and I have just shown you that not always you get the perfect image. So the other way of going to that is look at the three-vessel view. So you are in the four-chamber view. You go a little bit high. You go to the three-vessel view. We will zoom a little bit. We know we are there, but again, we can switch the Doppler on to see if we improve a little bit. I will raise a little bit the PRF. Okay, and you have the pulmonary artery here, and the aorta. And yes, thank you. That's the pulmonary artery, the ductus arteriosus. And this is the aorta. And that's, if I go a little bit down, then I see the descending aorta here, and that's where the ductus arteriosus joins. So if I have to go a little bit up, and that is the aortic arch, okay? And the aortic isthmus is here, so it's very easy. I would like to get rid of this aliasing, but I cannot that much, but okay, more or less. So the aortic isthmus should be here. Can we get a little bit more of persistence, or it is a problem? So we will ask the Doppler to be a little bit more persistent, so we have a nicer image. Okay, now, I will stop here and I will use the zoom. So you see, and more or less, you should look at the aortic isthmus is here, okay? So Let's see if nothing changed. We will set the pulse Doppler again. We will reduce a little bit the size of the gauge. We will use the zoom to be sure that we are there. And there we are, and I hope we get a better image now. We should reduce the sweep speed to get it nicer. It's at 4 now, okay. We will reduce the scale a little bit, the baseline a little bit down. So that is much more the typical image you get from an aortic isthmus. We don't see the retrograde flow. We should see it. Here we see it. Okay, I will reduce the PRF a little bit. No, a little bit higher. We should, the gain. Well, okay, it's not the best one you can get, but it's reasonable. And we can see clearly this typical notch of this reverse peak of the isthmus. It's a little bit contaminated with noise, but when you have a clean image, let's see if I can. Yeah, okay. And that is the typical shape. There is a positive diastolic flow. We should adjust it a little bit because there should be positive flow all the way through the diastole. And there is this typical retrograde flow that some authors consider that there is an artifact, and we are convinced that it is real, and it is due to the mismatch of the outflow between the aorta and the pulmonary artery. But anyway, that's a typical shape. Here you can really measure the aortic isthmus flow or the pulsatility index of the isthmus, okay? I will not do it because I am already suffering a lot with other things, and I probably will not find a way to do it right with this machine. And I think you get here the image. What else? Do we still have time? Do you want me to take a look at something else?
I will just ask very briefly, do we have the presenter for the first presentation, Dr. Everett, here? Okay. It seems that the presentation isn't uploaded. Has it been uploaded? Do you know? Should be. Okay. Would you check with the technician for us? Otherwise, what we'll do is switch you to the end and join your laptop. So in that case, Edward, I think that's probably enough since we have all our presenters here now. And then we'll carry on with the oral presentations. So thank you very much. Do we have any questions from the floor? Very well. So thank you, Edward, for doing that, and thanks to the nice lady for volunteering.
Thanks. Do you want me to show you the bigger?